tonight's presentation will be facilitated by Dr. Sudeep Shivakumar, Chair of Fellowship and Training Committee of Thrombosis Canada. Dr. Shivakumar is an Associate Professor in the Department of Medicine at Dalhousie University and a clinical hematologist at the Nova Scotia Health Authority in Halifax. He is currently the Director of Thrombosis and Anticoagulation and the Program Director for Postgraduate Education in the Division of Hematology. His practice includes benign and malignant hematology, but his clinical focus is on venous thromboembolism and anticoagulation. His research interests include malignancy-related thrombosis as well as medical education. Again, I remind you to use phones during the presentation so that the background noise doesn't interfere. And thank you, and Sudeep, for you.
Great. Well, thank you, David, and thanks to Thrombosis Canada for putting on this program. I will be monitoring the chat window throughout the program, so if you have any questions to write down, I'll be sure to bring them up to our speaker. And again, if you joined late, please mute your phones during the presentation, just the background noise. So it's my pleasure to introduce our speaker, Dr. Marc Carrier. Dr. Carrier is an international leader in this area. He's the current Vice Chair of Research for the Department of Medicine and a professor in the Faculty of Medicine and a senior scientist in the Clinical Epidemiology Program of the Ottawa Hospital Research Institute. He holds a Tier 2 research chair in venous thromboembolism and cancer from the University of Ottawa and a new investigator award from the Heart and Stroke Foundation of Canada. In 2015, he was the recipient of the prestigious Dr. Michel Chrétien Researcher of the Year Award for the SUM study, which was published in the New England Journal of Medicine and has really changed practice for venous thromboembolic disease patients around the world. His clinical research is in this area, venous thromboembolic disease and cancer, including cancer screening, prevention, and management. And he's currently the principal investigator on numerous peer-reviewed clinical trials. He has published important systematic reviews and has had multiple international speaking invitations to speak on the topics of cancer and thrombosis. And we're very happy to have him talk about a treatment algorithm in cancer-associated thrombosis. So, Marc, I'll turn it over to you. And again, just a reminder to everybody to mute your phones, please.
Thank you very much, Sudeep. It's a great pleasure, and really thankful for everybody taking a little bit of time to just generate a discussion about having a look on the latest evidence for cancer-associated thrombosis, treatment, data, management, and really when we have a look at the data, how do we incorporate that in clinical practice and how do we tailor anticoagulation for this patient population. Before starting, it's important to have a look at my disclosures. Honorarium received for talks and consultancy work is dealt through the hospital and used for residents and fellows research and education, but remains potential important conflict that you should be aware of. So over the next 40 minutes or so, I want to do a few things with you guys. I want to first have a look at what's the incidence of VTE in the cancer population. Does it have important clinical significance? Is it associated with increased morbidity, increased mortality? And if so, how do we create awareness around it? And how do we make sure that patients have a diagnosis early on and start anticoagulation, an effective anticoagulation management treatment right away? And there's been some new data around, so we'll have a look at the data, try to digest it all, and then at the end, hopefully we'll be able to include that into clinical practice and to tailor a management when we're doing clinical practice or when we're in clinic tomorrow. So before starting, it's always good to have an idea of the incidence of the disease we'll be discussing. And venous thromboembolism, so proximal lower limb DVT or pulmonary embolism, is not very frequent in the general population. We talk about 1, maybe 2 over 1,000 patients. But having a diagnosis of cancer will increase your odds of having VTE complication by 4-fold. And if that cancer patient is starting chemotherapy, that risk factor is increasing the odds ratio to 6.5-fold. So just adding these two very simple numbers isn't adding to 1 in 1,000, it's more 1 in 200. And we all know that the cancer journey is complicated. Patients are admitted to hospital because of complications from chemotherapy. They need to be admitted for chemotherapy deliverance. Sometimes they have central venous catheter for chemo or transfusion products or blood products. They often need surgery. They need biopsy. So the risk, you can just see that these are additional risk factors for venous thrombosis complications. So it just accumulates, and over time it will fluctuate quite a bit during the cancer journey. Hopefully this rate or the VTE rate complication will decrease when the patient is getting into remission of the underlying disease. But unfortunately, it tends to creep back when the cancer is progressing again or at the end of life, and we'll have a discussion around that as well. But you can see there's quite a bit of fluctuation. At the end of the day, when we're talking about the incidence of the VTE in the cancer population, we're not talking about 1 in 200, we're talking about 1 in 20. So about 6 per 100 person years, cancer patients will actually have VTE complication. That's why we see them so frequently when we're on the clinical wards or in our clinics, and that's why we need to give them some attention. And it's one thing to say that they're frequent, but they seem to be associated with important morbidity as well, and I'll come back to that in a minute. Now, when we think about VTE in cancer patients, we often think about the very hyperthrombogenic type of tumors. Classical ones would be pancreatic cancer, stomach cancer, glioma, or brain cancer. We have here on this slide, I've highlighted the incidence of pancreatic cancer, for example. The incidence of VTE is up to 15%, so that's almost 1 in 5 in this patient population, so very common. But when you look at it, when you have a reflection of who you see in clinic, really who we see, or the bulk of the VTE that happens in the high incidence type of tumors. So really it's the man with prostate cancer, the woman with breast cancer, the patients with lung, just because although the incidence of VTE complication is tumor type is slightly lower, these cancers are so common or so prevalent in our population that we see these clots more frequently in these tumor types. Of course, we'll see pancreatic and stomach, but they don't come as frequently. And this is important to keep an eye on, because when we're going to look at the data, looking at the new data comparing direct anticoagulant to rheumatoid heparin, we want to make sure that the baseline characteristics are actually generalizable to the patient population or folks we see in the clinic on a day-to-day basis. So it's one thing to say that these complications are common in our cancer population, but it is associated with increased morbidity or mortality. So as you know, having DVT now, cancer is getting to be a chronic disease. People live a long time with underlying tumors and often develop now post-lytic syndrome. Folks with PE, a third of them will have chronic dyspnea or will have what we call post-PE syndromes or exercise intolerance afterwards, so which is really affecting their quality of life. But more importantly, it's also increasing their mortality. And thromboembolism, so arterial and venous clots, are the second leading cause of death in cancer patients, equal in infection. And the annual death rate of VTE in the cancer population is about 500 or 100,000 people. So that's 47-fold increase compared to non-cancer patients. And it's important as creating awareness to patients and healthcare providers, nurses, pharmacists, doctors, medical oncologists, general internists, primary care docs, so that they give a little bit of information about the signs symptoms of DVTs and PEs to cancer patients, so that they know to seek medical attention, because often they think their symptoms are related to chemotherapy complications or the underlying tumor, and they're often delaying seeking medical attention, therefore delaying proper diagnostic measures for confirmation of their clots and then delaying anticoagulation therapy. And that's probably reflective in the increased morbidity and mortality. So it's really important to stress that to our colleagues across the hospitals or the wards or the clinics that we work with. And right now, if you look at the clinical practice guidelines, today on November 20th, you would see that the first line of therapy is rheumatoid heparin. And the latest set of guidelines from the American College of Chest Physicians, was published in 2016, so a couple of years back. And you can see that in patients with DVT of the leg or PE and the setting of cancer, they recommend rheumatoid heparin over vitamin K antagonist, and that's a grade 2B recommendation, but also over all the different direct anticoagulants, so dabigatran, rivaroxaban, apixaban, or edoxaban with a grade 2C recommendation. And this is slightly old data now, right? But we understand why they did that. So when you look at the medical literature comparing low molecular heparin to vitamin K antagonists or warfarin, target INR between 2 and 3. There's 6 randomized control trials that have compared these 2 treatment regimens, and what it shows is that low molecular heparin is providing a 50% relative risk reduction compared to vitamin K antagonists without increasing the risk of associated major bleeding. And it's important that when we think about efficacy and safety in venous thrombosis trial, the efficacy measure is always the risk of having a second clot or recurrent event despite coagulation, and the safety outcome measure is usually major bleeding. So when you compare low molecular heparin to vitamin K antagonists or warfarin, it was really just increasing the efficacy by low molecular heparin without any additional risk of bleeding. So that's why it was the recommended treatment. Now, until very recently, we only had indirect data comparing low molecular heparin to the direct oral anticoagulant. So that's why the recommendations are much lower for that particular recommendation over, for example, the dabigatran, rivaroxaban, apixaban, and redoxaban. And it's not until very recently that we had a couple of randomized control products been published that maybe is changing the data. And that's why the purpose of the talk today is to have a reflection of what the data, what the clinical practice guidelines are saying. But since then, we have a little bit more data. Is that now ready to incorporate in clinical practice, and what do we do when we decide on the type of anticoagulation for these types of patients? And there's 2 randomized control trials that have been published. The first one is called the Hokusai VTE cancer trial. It was presented in the American Society of Hematology in 2017 and published in the New England Journal in February of 2018. And this is a randomized controlled trial directly comparing the direct oral anticoagulants to low molecular heparin. So patients with cancer-associated thrombosis were randomized to low molecular heparin, dalteparin, at a dose of 200 units per kilogram per day for the first month, and dose reduction to 150 units per kilogram per day thereafter for a minimum intent of 6 months and up to 12 months. And then the comparator or the intervention was 5 days of low molecular heparin, any type of low molecular heparin as being fit by the local investigator, followed by edoxaban at a dose of 60 milligrams PO daily. And then patients could have a dose reduction if they were less than 60 kilograms, had a creatinine clearance between 30 and 50, or if they had interaction with medication that interacts or in pathways of the glycoprotein P. And then the dose reduction was at 30 milligrams, but a large majority of folks received 60 milligrams PO daily. Now, what's interesting with the Hokusai VTE cancer trial is the primary outcome measure. So it's not the usual one that we just talked about. It's a combination of efficacy and safety. So their primary outcome measure was recurrent VTE or first major bleeding event. And then the randomized trial was an open design, so people knew if they were obviously self-injecting or taking a tablet, and it was a non-inferiority trial design. So, before starting, as we discussed before, we want to have a look at the baseline characteristics of the patients that were included in the trial. And when you look at the baseline characteristics, you can see that folks had a mean age of about 65, which is standard of care for cancer-associated thrombosis trials. But two things I want to emphasize here. The first thing is that a third of the patient had incidental PEs, so it's the first time we're actually randomizing incidental PEs in the treatment trial. And that's something we've seen more and more. I'm sure you'll agree with me, more and more frequently in clinical practice, so that's important to keep in mind. And then when you look at the treatment duration, you can see that there's a discrepancy between the edoxaban arm and the dalteparin arm, about a month difference. And then remember, this trial had to have an intent of 6 months and up to 12 months, so people knew if they were self-injecting or taking a tablet. And the difference between the 1 month might be because of patient's preference. We'll come back to that. But certainly important to keep in mind when we have a look at the data because it may influence how we interpret the data. Now, there's also the type of tumors. And as I mentioned before, it's a mixed bag of type of tumors and metastatic disease and staging, but that's usually the case. But more importantly, when you look at the type of tumors, it's really the ones that we see frequently, so colorectal, lung, GU, breast. And of course, we see pancreatic and stomach, but they're not as common, and that's reflective of what we see in clinical practice. The Hokusai VTE cancer trial also provided us with the type of chemotherapy patients were on at randomization. And this is important to keep in mind because we'll come back to that later, but rectal anticoagulants have less drug-to-drug interaction compared to warfarin, of course, less drug-to-food interaction, but they still have some drug-to-drug interaction that are important to consider, especially if there's any interaction with CYP3A4, glycoprotein P. And this is important to remember. So this is at least an effort to show us what type of chemotherapy patients were taking at the time of randomization. There's not a lot of checkpoint inhibitors or immunotherapies. That's important to keep in mind because these might be having side effect more in the inflammatory role or types of side effects. So that's important to consider. There's maybe not as much as bevacizumab as one would like, but nonetheless, it's important to just have a reflection. The data, it is what it is, and then we need to incorporate that into clinical practice. So let's have a look at the primary outcome measure. So remember, it's a composite primary outcome measure of first recurrent VTE or major bleeding. And when you look at the two treatment arms, you can see there's no difference. The curves are really overlapping, and really it's an hazard ratio of 0.97, and that is statistically significant for non-inferiority, and therefore the conclusion is that edoxaban is non-inferior to dalteparin for the management of cancer-associated thrombosis. Now, you're probably wondering, well, that's fine, Marc, but I usually think about cancer-associated thrombosis not in 12 months, but more over 6 months, because most of the other trials have compared treatment regimen over 6 months. When you look at the second line here, so you look at the primary outcome measure for the first 6 months, you can see that the hazard ratio is again very similar, 1.01, remains statistically significant for non-inferiority. And then remember, we said it that there's discrepancy in the time of the intervention. So looking at the per protocol or when patients were taking the study intervention is important as well. And you can see that the hazard ratio remains around 1 with a P that is statistically significant for non-inferiority. Now, the primary outcome measure is one thing, but what we really want to have a look at is the different components of that primary outcome measure. So on the left-hand side, we have efficacy. So what's the risk of recurrent VTE or having a second clot despite anticoagulation? And you can see on the left-hand side that patients taking edoxaban had a lower risk of having a second clot with an hazard ratio of 0.71 that was not statistically significant. The two curves seem to be separating around 2 to 3 months. In the middle, we have the safety outcome measure, so major bleeding. And you can see that edoxaban or patients taking edoxaban were more likely to have major bleeding events. The two curves seem to be separating from randomization, associated with an hazard ratio of 1.71, and that was statistically significant. On the right-hand side, it's the event-free survival curve, so a combination of risk of recurrent VTE, major bleeding, and death. And you can see the two curves are overlapping, and really there is no difference between the two treatment regimens. Now, we're all clinicians, we're doctors, pharmacists, nurses, healthcare providers, and the first thing is obviously do no harm. So when I'm saying, there's a statistically significant increased risk of having major bleeding complication if you're taking edoxaban, often people are saying, well, can we predict what type of bleeding and in which type of patient? So having a look, when we look at the type of major bleeding and we stratify them a little bit further, you can see that there's not a whole lot of difference between fatal bleeding events between the two treatment arms or with intracranial hemorrhage. But the bulk of the discrepancy seems to be with upper GI bleeding, 17 versus 3. And there's no difference for lower GI bleeding as well. So really the bulk of the disease seems to be coming from upper GI bleeding complications. And then when we look at the gradation of these major bleeding, because major bleeding can be quite heterogeneous in nature. It could be, for example, bright red blood per rectum requiring 2 units of packed red blood cell to visit the emergency room to dying from a fatal major bleeding event. They've tried to grade the severity of bleeding from a gradation system from 1 to 4, where 4 is intracranial bleeding or dying from bleeding, and 3 is some type of bleeding that really needs urgent intervention or procedure. And you can see that when you look at the 3 to 4 grade of major bleeding, there's not a whole lot of difference between the two treatment arms. However, this gradation of bleeding is relatively new. Some people, it has never really been validated. So it provides some information, but you need to be careful about the validity of the information that it's translating. Now, we mentioned that there is discrepancy in the intervention. It seems like the difference in a month is really secondary to patient's preference. And as I mentioned before, there's a discrepancy in the rate of upper GI bleeding complication in patients taking edoxaban Well, it looks like over 70% of patients that had upper GI bleeding actually had GI tumors. And therefore, that might be something to keep in mind when we're tailoring anticoagulation regimen. Maybe we'll need to be very careful if a patient has a GI tumor, depending on stage and status, of course, but maybe edoxaban or direct anticoagulant may not be the first choice for these types of patients. Now, like anything, there's always limitation to studies, and for limitation for Hokusai, so there was some dose reduction associated with edoxaban, so it can be a strength, it can be a limitation. For Hokusai cancer VTE, there's not that many patients that underwent the dose reduction, so maybe there's a little bit of lack of data there. Dose exposure, as I mentioned, shorter duration for folks on dalteparin. And there's, when we look at the anti-cancer therapy, there's maybe no experience with immunotherapy and checkpoint inhibitors. As I mentioned, these are often linked to severe or complication with inflammatory type of responses that can lead to colitis and mucositis. So one needs to be very careful because maybe there's a little bit of lack of data for these particular treatment regimens. Now, the second trial was published in the JCO a little bit later on in 2018, and it's the SELECT-D pilot trial. So the number of patients enrolled is much smaller compared to Hokusai VTE. So we're talking, they were hoping to have 530 patients. Patients were going to be randomized to dalteparin, the same dose regimen that we talked about, or rivaroxaban, so a direct 10 inhibitor again, but 15 milligrams PO BID for the first 21 days and dose reduction to 20 milligrams PO daily thereafter. And initially, they wanted to do a second randomization after 6 months, thinking maybe we can answer 2 questions with one trial. And the second randomization was really to try to figure out what's the length of anticoagulation, but they really had a hard time randomizing patients, and we really abandoned the second randomization. So today we're only going to focus on the event rates during the first 6 months, so from the day of randomization up to 6 months. And what's also slightly different compared to Hokusai VTE is that the primary outcome measure was recurrent VTE and not a composite outcome measure, and their primary secondary outcome measure or safety outcome measure was major bleeding and clinically relevant non-major bleeding. Now, it's interesting because in SELECT-D pilot trial, remember it was a pilot trial design, so it wasn't really powered to detect any difference between the 2 treatment arms. So they weren't really planning on adjudicating all the events during the trial conduct. So it was done blindly, but it was done post-study trial recruitment. So that's important to keep in mind because not necessarily all suspected events were adjudicated as it is usually the case. And they actually changed the sample size a little bit. So remember, they were hoping to have 530 patients, and the sample size calculation was made on having an event rate in the rivaroxaban arm for an upper bound of the 95% confidence interval that's going to be less than 8%. Now, they realized that maybe they didn't need to be so precise, and they were happy to have an upper bound up to 9%. That decreased the sample size from 530 to about 400. So today, when I show the result, we'll really talk about 406 patients. And then the second thing is the DSMB, or Data Monitoring and Safety Board, probably realized that there was an increased risk of having upper GI bleeding and asked the study investigators to stop enrolling patients with upper GI tumors during the trial conduct. And therefore, when we look at major bleeding, we'll have to keep that in mind because they stopped enrolling patients with GI tumors or upper GI tumors at some point. So we'll have to keep that in mind as well when we look at the major bleeding. When we look at baseline characteristics, it's very similar to what we've seen in Hokusai VTE. The main difference, though, is in the number of patients with incidental VTE or incidental PEs. So remember, in Hokusai cancer VTE, it was about a third. Well, for SELECT-D, it was about 50%. And that might be important to keep in mind when we interpret the data as well. Now, when we look at the event rates, we're looking at risk of recurrence, having a second clot despite coagulation or major bleeding, or clinically relevant non-major bleeding. Well, you can see, again, we can't really compare the 2 arms because it wasn't a study that was designed for that, but you can see that the rate of recurrent VTE was lower in patients taking rivaroxaban, but that came at a cost of increased risk of major bleeding, so somewhat similar to what we've seen in the Hokusai VTE cancer trial. And when we look at clinically relevant non-major bleeding, there's certainly an increase in the risk of major bleeding And when we look at the site and type of bleeding, it was really urothelial bleeding in patients with tumors. So when we again tailor anticoagulation, maybe we'll have to be careful in patients with GU tumors, and maybe the best fit may not be rivaroxaban, at least early on, but we'll come back to that in a minute. And then when we look at major and clinically relevant non-major bleeding, it was again similar with increased risk in patients taking rivaroxaban or direct anticoagulants. Now, when we look at the time to event curve analysis, so they are very similar to what we've seen before. So this is the risk of recurrent DT. We're having a second clot despite anticoagulation. You can see that folks on rivaroxaban were at lower risk of having a risk of second clot, and that seems to be separating after 2 months. And when you look at major bleeding, patients on rivaroxaban higher risk of having major bleeding, it seems to be separating it since the time of randomization. So somewhat similar. And again, there's always limitations to studies. So again, for SELECT-D, it's a pilot study design. They slightly changed to a study design during conduct, decreasing the sample size. Maybe some selection of patients because they stopped enrolling patients with upper GI tumors during the trial conduct, and that's important to keep in mind for sure. But, you know, when there's 2 randomized controlled trials, there's always someone that will do a systematic review and meta-analysis. And just to illustrate, when you look at the risk of recurrent DT on the top or risk of major bleeding on the bottom, that when you combine the 2 studies together, you have a lower risk of recurrent VTE for folks that are taking a direct anticoagulant, these particular cases, doxaban or rivaroxaban, compared to low molecular heparin. And when you look at the bottom for bleeding, that comes at a higher risk of having major bleeding episodes, and that was statistically significant. So, you know, at the end of the day, you're probably wondering, well, what should we do? What else should be considered? Well, I mentioned the drug-to-drug interaction, and I mentioned that, of course, we know direct anticoagulants have less drug-to-drug interaction compared to warfarin. There's less. They're not really as they do have substrate in important metabolic pathways, but not as many. For the direct anticoagulants, they are metabolic in the transport pathways of the CYP3A4 and glycoprotein P, and it's different from one DOAC to another. So that's also important to keep in mind. And if you just looked at what type of chemotherapy can interact with these different pathways, where there's a ton of them, and it's hard to keep in mind, and I'm not saying that these are all clinically important or relevant, but I'm saying this because maybe it would be worthwhile to interact with our medical oncologist colleagues or pharmacists in order to see, especially if we're using combination chemotherapy and there's possible multiple interaction, and when you factor in renal dysfunction, you know, maybe some of these may become important and should be kept in mind when we're initiating or deciding on the type of anticoagulation a patient should be on. Now, there's clearly other factors to consider, right? I think we all agree that the type of cancer and burden of cancer and DPE are important. It's not the same if you have a metastatic, pancreatic cancer versus a resectable colon cancer that underwent surgery on adjuvant chemotherapy. Likewise, it's not the same thing if you have a distal lower limb DVT versus a submassive PE. So these are important to keep in mind when we're tailoring anticoagulation. We'll come back to that. But there's other important things like renal impairment, GI surgery, absorption, body mass or body weight might be important. There's a recommendation from the International Society of Thrombosis and Hemostasis saying, well, if your body weight is over 120 kilograms or less than 40 kilograms, you may want to be careful with direct anticoagulants because we're not sure if it's the right level or the level is the expected range. And then pre-existing condition and co-medication like antiplatelet, and we often don't clean the medication on our patients too frequently, but when you have a new indication for anticoagulation, it might be the right time to say, do you still have the indication for antiplatelet, yes or no, and can we just get by with anticoagulation to avoid the additional bleeding? And of course, what's most important is patient's preference, and you can sit down with a patient and have a discussion. I'll come back to that, and practically, drug coverage is really important. Accessibility is important. There's differences from one province to another, but drug coverage is really important to be able to use this in clinical practice. Now, let me come back to patient's preference in a minute, because when we see these patients in our clinic, they don't necessarily see themselves as a VTE or a clot patient. They see themselves as a cancer patient first. And really, when they see us in clinic, the first thing they have on their mind is, please don't interact with my anti-cancer treatment. It can be chemotherapy or surgery or radiation. we just want to make sure we're not going to delay anything or interact with it. So that's important to address that when we talk to patients. The second thing they have on their mind is efficacy and safety. And the last thing is route of administration can be sub-Q or PO. And the reason why I'm saying this is so we might be going back and forth between different types of anticoagulation. That seems to be perfectly fine for cancer patients if number 1 and 2 are already covered. And this is data coming out from the UK. Simon Noble, one of the palliative care doctors doing a lot of qualitative research in cancer-associated thrombosis. I've interviewed a lot of patients and interviewed patients during the low molecular heparin era, so when that was the first end of care, and also did the same thing with the SELECT-D trial and found the exact same results. So this thing here, the patient's perspective remains very important, even with the new results that we just talked about, and that's important to keep in mind when we make a decision. So at the end of the day, I think we'll have to, it would have been nice to have an option that, we were going for low molecular heparin for everybody to an oral agent where we're going to a tablet for everybody, but I don't think it will be the case. I think we'll have to sit down and have a discussion with patients and do an individualized approach. It will be dependent on risk of recurrence and the risk of bleeding, if there's any drug-to-drug interaction or other patient factors, and then we'll have to come up with a decision, and that might change during the cancer journey depending on what they have to go through. So some folks have given some thoughts on this, and the International Society of Thrombosis and Hemostasis has a subcommittee on malignancy and cancer, and they come up with some suggestions or things to think about. And they said that maybe the use of direct anticoagulant is suggested for patients with acute diagnosis of VTE at low risk of bleeding and no drug-to-drug interaction. I'll come back to the risk of bleeding definition in a minute. And they emphasize redoxaban and rivaroxaban are the only DOACs for now that has randomized controlled trial evidence. And again, as we mentioned, low molecular heparin remains an acceptable alternative for these patients, depending on patients' preference and other things to consider. And on the flip side, low molecular heparin is suggested for patients with an acute VTE at high risk of bleeding. And the high risk of bleeding is luminal GI tumors or with intact primary or active GI mucosal abnormalities with duodenal ulcer, mucositis, or some form of colitis. They need to be very important. That's why when patients are undergoing immunotherapy, that's also important to keep in mind. But keep in mind that, as it was for the previous slide, DOAC might be an acceptable alternative if there's no drug-to-drug interaction and curing systemic therapy exists. So this is great, right? It provides us with a little bit of guidance, but doesn't necessarily go through all the details of what's the thought process or what are we going through in our head when we make a decision about anticoagulation. So a group of experts in Canada has decided to just sit down and come up with what should be the reflection and things to consider. And they're not recommendations, they're just suggestions. And you take it or leave it, but it provides at least a framework of what one can think about or should think about when they make a decision about anticoagulation. The first thing that was mentioned is maybe the risk of bleeding. And there's some things that are associated with a higher risk of bleeding. It could be thrombocytopenia, antiplatelet agent, recent major bleeding, sometimes renal dysfunction. They're not, maybe on their own individually, they may not be associated with a very high risk, but especially when they're in combination, we should be careful and at least be mindful that this patient might be at a higher risk of bleeding and therefore maybe tailor anticoagulation to favor something that's associated with less major bleeding. The second thing is, and I think we talked about that GI tumors seem to be at a higher risk of having upper GI bleeding complication. And same thing with GI tumors, they seem to be having immature urothelial type of bleeding complication in SELECT-D, especially in clinically relevant non-major bleeding. So these types of tumors, you should be careful about using a direct anticoagulant. And at least initially, maybe low molecular heparin might be a better option. And then finally, the drug-to-drug interaction, as I mentioned, no expert in it, and it's hard to wrap our head around it, and often we're all very busy. So asking the help of a pharmacist might be helpful to provide us some guidance, especially to just know, is it something that we should, clinically relevant or not, and should we be worried or not? And just based on this, make a decision. A decision is not forever. It's just that we need to reassess patients frequently, and things always change. They might need to go for surgery. They may need to change chemotherapy. They may have other things in their life. They may become very tired of the needles and needle phobic, for example. So this is it's a circle or a cycle in order for that maybe to be reassessed, and that the anticoagulation can be tailored accordingly. So obviously there's, cancer-associated thrombosis is common in the general population. And, the past few months have been very exciting because now we have more arsenal in our toolbox for management of cancer-associated thrombosis, more options for patients. We just need to use them wisely and consider risk of recurrence and bleeding, and obviously factor in the patient's preference into it. And more importantly, we see our patients frequently and generate discussion with medical oncologists, pharmacists, and nurses in order to make the right choice for patients. And I think at the end of the day, we have more options, and that can just be more positive for a patient population overall outcome. And with that, I'll just stop. I'll take any questions, generate discussion. I know some of these things might be controversial, so please feel free to disagree, and then we'll generate good questions. Thank you for your time.
Great. Well, thank you, Marc, for excellent review of the recent evidence in cancer-associated thrombosis, and there really is a lot of changes, so it's been very helpful. I'm going to open it up to questions, and you can either unmute your phone and ask a question, or write it in the chat box, and I can read it out loud. But I might just take this opportunity to start things off. Marc, the algorithm was very helpful, and the data for the DOACs is, great, especially in that it includes incidentally found clots, because we are, tending to treat these. I'm just wondering what your approach to clots that are not in the lower limb or the lung is, because, with patients with cancer, we are seeing, a lot of upper extremity DVTs or unusual site thrombosis, especially, intra-abdominal clots on staging CAT scans, for example. Do you think the algorithm can be extended to that, even though, they may not have been included in the trials? What's your approach?
Well, Sadiq, it's a fantastic question. As you're well aware, there's not a whole lot of data for these unusual sites or upper extremity PICC line associated, for example, deep vein thrombosis, even with low microwave heparin. So for years, we've been using low microwave heparin, extrapolating data from the low microwave heparin trials, thinking now, well, the upper extremity should work just as well as for a lower extremity. But really, there's not that much data. And I think we have probably more clinical experience with the low microwave heparin for these unusual site or different site type of thrombosis. But I think for the most part, if you think about all the risk factors that are going through the algorithm, you should probably come up with a very similar decision at the end. The only thing that might be slightly different and for which we don't have a whole lot of data is for central venous line associated upper extremity deep vein thrombosis. There's just a couple of pilot trials looking at warfarin, a retrospective study looking at low microwave heparin, and more recently a pilot trial looking at rivaroxaban with the same doses that we talked about, the same dose as in SELECT-D. It was associated with a low risk of, it's only 70 patients, a low risk of recurrence, but the risk of major bleeding was relatively high. There was 9 out of the 70 patients that had major bleeding. There's 11 major bleeding in 9 patients over the 70 total sample size. So, maybe these clots have a different pathology or physiology. I don't know. I tend to be maybe a little bit careful, especially early on. Now, the same group is doing another trial looking at low microwave heparin for the first week before using direct anticoagulant. I might buy some time, but so for the most part, I think the algorithm would be helpful. I'd just be a little bit careful with upper extremity catheter directed because we're not sure. The data might be slightly different.
Great, that's very helpful. Thank you. I'd like to open it up for questions from the group. So please just unmute your phone, and we'll take any questions for Marc. And just I'll just ask one more question just while we're waiting. But the duration of anticoagulation, what I had done in my practice was, always based it on the clot trial, which was 6 months of anticoagulation and then reassessed and continued if the bleeding risk was not super high and the cancer was still active or they're receiving therapy. The algorithm you presented suggests, more frequent reassessment, pretty much every 3 months. That may help in terms of the patient who has the more provoked clot right after a surgery for cancer. But do you think now that the solid 6 months for everybody is not really the way to go, and really we should be just considering this as kind of a continual reassessment?
Right. So, we did put 3 months there just to try to give some guidance, right? So there's nothing about the 3 months that is important. It could be sooner than 3 months. It could be 6 months. It's just meant to readdress things when things are changing. It could be the patient's preference is changing, the chemotherapy is changing, they need to go for a surgery. We just need to keep an eye on these patients a little bit more frequently, I think, than we used to in the past. Just at least early on, as we're learning to use the direct anticoagulants for cancer-associated thrombosis, and then things might change down the road. But for the time being, it was just to provide a time frame guidance around it. But you're right. I think for overall anticoagulation purposes, you need to readdress your patients. But if they have underlying tumors or they're undergoing cancer treatment, you should probably continue some form of anticoagulation, because the risk of recurrence would be higher if they stop anticoagulation. The risk of having a second clot would be too high and probably worthwhile continuing compared to the risk of bleeding. There's a little bit of data with the low-molecular heparin for that with the TICAT and the Delta-CAN study that followed patients up to a year. The Hokusai VTE also followed patients for a year, but we don't have the data post 6 months just yet.
That's great. Thank you. And any questions from the audience? And just make sure you unmute your phone.
It was clear as mud, Sudeep, so
yes,
we're good.
You answered everybody's questions with the presentation, Marc. Okay. Well, with that,
if there's any additional questions, Sudeep, and if people want to reach to me directly, they can feel free to send me an email. It's never a problem.
Hello?
Oh, go ahead.
Yeah. Sorry, I just have a quick question. What are your thoughts on superficial thrombophlebitis in the cancer population? Because we certainly see that too. It's catheter-associated.
Yeah, we see that. Yeah, you're quite right. We see them quite frequently for basilic vein and cephalic vein thrombosis, and there's not a whole lot of data for superficial vein thrombosis to begin with, so that's reassuring. That means that pretty much whatever you decide to do is probably reasonable. There's certainly even less data in the setting of cancer, and I can assure you there's no data for upper extremity catheter-related superficial vein thrombosis. But if we extrapolate from the high-risk group of the lower extremities, so those that are at least 5 centimeters long, causing a lot of redness and discomfort, they seem to be doing a little bit better with anticoagulation. Now, it could be intermediate dose low-molecular heparin. It could be direct anticoagulant. So there's data with rivaroxaban 10, for example. There's a little bit of data that will be coming out shortly from McMaster University. There's data from Germany as well. So rivaroxaban 10 seems to be effective, intermediate dose of low-molecular heparin, but I wouldn't continue long-term. It would be symptomatic treatment, maybe up to 30 to 45 days, and then I would stop thereafter. Now, if it's really self-limited, often patients will just do well without any anticoagulation, especially if they're at high risk of bleeding. So, warm compresses around the area, sometimes Voltaren cream or some Pensade drops where the phlebitis is might be helpful. And then if they do better over time, I don't tend to re-image them. But if they do worse, or if they seem to be progressing, then I repeat on ultrasound in 5 to 7 days, just to make sure they did not extend into a deep vein where you'd have an indication for full dose anticoagulation at that time.
Thank you.
Thank you for your question.
And any other questions? Excellent. So I'd like to take this opportunity to thank you, Marc, for the excellent presentation and really clarified a lot of things, and to thank the audience for your time tonight. I will turn it over to David to close out the program, and have a great night. David?
Well, thank you, Sudeep and Marc, for the great presentation and facilitation tonight. We all appreciate it. Thank you, everybody, for participating in the webinar tonight. And as I mentioned, the webinars will be posted on our website in the next few weeks. If you wish to listen again or pass the link on to others who may be interested. On behalf of Thrombosis Canada, thank you very much. Good night.